First of all, we need to think when we have to deal about pancreatic solid lesion, when those are incidental findings on cross-sectional imaging. We know that many times nowadays we have people that perform MRI for other reason and comes to us with a mass in the pancreas, or because those are new findings during follow-up imaging of screening programs in familial disease or previous neoplasm that are on the follow-up studies, or, and this is the most common part, where people send us patients for a clinical suspicion of a pancreatic lesion. And what are we dealing with neoplasm and benign lesion? And among those is the most important thing when we look into a solid lesion in the pancreas. The most important thing is to perform a differential diagnosis between a neoplasm and benign lesion. And among the neoplasm, probably the most important thing is to differentiate pancreatic adenocarcinoma from other not so malignant lesion. Why? Because we know that pancreatic adenocarcinoma is the worst, actually the worst cancer in Western countries, has only 7% overall survival in 5 years, and the incidence of pancreatic cancer is increasing. There are data that shows that in 2030 probably pancreatic cancer will be the second cause of cancer in Western countries. And if we look to the patient that have a pancreatic cancer, we know that most of the patient, 90% of the patient that comes to our attention have a large pancreatic cancer. So this patient have at least 20 millimeter lesion, and most of them are not eligible for surgical treatment. And if we look to the best possible patient that we can diagnose with pancreatic cancer, who is a stage 1A patient, the 5-year survival rate is only 40% due to metastatic disease. So we now know that if we want to select a patient with pancreatic lesion who is curable, this is a patient with a PANIN-3 lesion and not other kind of lesion. So sometimes we, as I told you, we have to deal with findings, incidental findings. This patient comes to our attention because transabdominal ultrasound suggests a dilated pancreatic duct, and the MRI was completely negative. And we have found here inside, right inside the pancreatic duct, a very small lesion. This is a carcinoid tumor, so-called serotoninoma, involving the pancreatic duct. But in most of the incidental lesion that we found during our daily work is if we are dealing with pancreatic cancer screening programs, because this patient has an increased risk of developing pancreatic cancer, and EUS and MRI are considered the best modalities to perform the screening in this patient. But if we go back to the real life, usually in real life we have a patient with a clinical suspicion of pancreatic cancer. And there are 3 possible situations, because in all the patients with the clinical suspicion of pancreatic cancer, every time we do multi-detector radical CT. So multi-detector radical CT could be negative, or could be doubtful, or could be positive. In cases of multi-detector radical CT negative, we know from the literature that CT has problems in depicting lesions less than 2 centimeters on 2.5 centimeters. These are all data from the literature, and if we look to more recent data of MRI and multi-detector radical CT, we see that the sensitivity and specificity are increased along the time because we have new machines, new technologies. But again, if we compare multi-detector helical CT and EUS in the detection of the lesion, and particularly if we consider a very small lesion like insulinoma, we see that there is a clear advantage of EUS in depicting lesion small than 2 centimeters as compared to helical CT. And if we look also to the patients that are coming with a very difficult disease, which are recurrent acute pancreatitis, where it's very difficult to depict a lesion inside. This is an abstract presented at the DDW last year. They found that they've studied nearly 10,000 patients with acute or recurrent pancreatitis with negative cross-section and imaging, and they had performed EUS in 1,000 of them, and they found 2.6% of malignant lesion. And when the EUS was negative in this patient, the lesion, there was no lesion in the follow-up, so the value, predictive value, was completely negative. Dealing with the everyday practice, we know that there are many times we have an helical CT suggesting or a diffuse enlargement of the pancreatic head or something more specific. When we see that EUS, if we perform EUS in this patient, we can depict the malignancy up to 22%, and particularly if we add FNA to the EUS, we can have a sensitivity nearly 90% with a specificity around 98%. And in cases of a patient with a negative EUS result, this is a very old paper, but it's still on the market, you do not find pancreatic cancer in the follow-up. So the negative predictive value of EUS in expert hands is very high. When multi-detector helical CT is positive, we know that we can have the lesion away from the vessels or very close to the vessels, or the lesion can involving, like in this case, the celiac trunk and the supramesenteric artery. And we know that if we add EUS and multi-detector helical CT, their positive predictive value is around 95%. So this means that EUS and multi-detector helical CT together are very able to rule in the involvement of the vessels, are less able to rule out the involvement of the vessels. But when we have depicted a lesion into the pancreas, what do we need to do? Do we need to perform FNA or not? Or not? There are several data on that. We know from the literature that there are already on the papers meta-analysis that show that pulse sensitivity and pulse specificity in the diagnosis with using USFNA is very high, nearly 85 and 98%. And particularly if we look to the diagnostic accuracy studies, the sensitivity is 91% and pulse sensitivity specificity is 97%. So it seems that really FNA affects and improved our capability to perform the diagnosis. But this is a consensus from the surgical point of view, published in 2014 on surgery. This is a consensus among surgeons. And in their conclusion, they suggest that if the patient has a lesion and the lesion is deemed to be resectable, there is no need to go further to perform biopsy, but the confirmation of malignancy is only intended for the patient who needs to perform chemotherapy as a neoadjuvant treatment. Obviously, I'm the sonographer, and I don't agree, because very recently there has been published a multi-center trial. Many of the authors are seated in this room, showing that if we consider the small lesion into the pancreas, most of those lesions are not pancreatic adenocarcinoma. Most of those lesions are neuroendocrine tumors or benign lesions. So the outcome of this patient is completely different as compared to the patient with pancreatic cancer. So you can differentiate this patient only performing FNA and not resecting this patient. In these cases, more than half of this patient should have been resected inappropriately. So, and this is true because if we look to this lesion that you see here, this lesion seems to be the same lesion, but those are not the same because this is autoimmune pancreatitis, this is a cancer, and this is a neuroendocrine tumor. So probably the only thing that can differentiate clearly this is performing the biopsy. As somebody said, tissue is the issue. So why not biopsy? There is the problem can be complication or seeding. We know from the literature the complication of biopsies from the ESG guidelines that general complications are like the standard endoscopy, and the rates of complication in USFNA is more frequent in cystic tumors as compared to the pancreatic, the solid tumors. And if we look to the literature, we know that if we perform the FNA, the risk of peritoneal recurrence or peritoneal seeding is less, significantly less as compared to the standard biopsy, transcutaneous biopsy. So, and if we look, if we think about the possibility that EUS FNA could affect the outcome of the patient, this paper published on GAT 2015 by the Mayo Clinic, show that patient that has performed FNA in the beginning of their process as compared to the patient who had not performed FNA had the same outcome. So EUS FNA doesn't reduce the survival of these patients. So coming back to the first slide, if we consider the PDAC and we are dealing with a stage 1A that has a survival rate at 5 years of 40%, what could be the next step? What could be the evidence in the future? The evidence in the future, and this is a paper published this year by our institution on Lancet, that probably also the patient with the stage 1A disease, so the resectable patient, have an improved survival if they are treated by neoadjuvant treatment before upfront surgery as compared to the patient who perform upfront surgery. So this means that all these patients need to perform USFNA in the beginning of their history before doing any kind of treatment. And this is why these are the ESMO, so the European oncologist guidelines, shown that in their conclusion that US-guided fine needle aspiration must be recommended in patients with pancreatic solid lesion, especially in doubtful cases, and percutaneous biopsy of the pancreas is contraindicated in all potential resectable cases. So I served some minutes. We know now that, and we can conclude that US must be considered as the best method to diagnose and evaluate pancreatic solid masses. And nowadays, I think that USFNA must be considered in all patients, particularly in those in whom affects the therapeutic strategies. And I hope to see you in Milan in March.